cannabinoids plant. Research in cannabinoids and cannabis has exploded in the last 2 decades, I guess you could say. Since the cloning of the CB1 receptor, there's been an explosion. Over here in '64 was when we first discovered the chemical structure of tetrahydrocannabinol, THC, and there was a concomitant increase in research. So you can see here that this has sort of helped to validate the science. And this is basic science research, I should specify. This is about the pharmacology, the lab, basic biomedical facts, basic science. Not so much in the human side of things. Because of that science, we actually have cannabinoid medicines in the American pharmacopoeia again today. Since 1985, we've had a pill called dronabinol, which is a chemical that's found in cannabis, THC, as I said earlier. Since 1985, we've also had a chemical called nabilone, medicine, which has been in perfectly legal use, and it's a very similar structure to THC. Both of these have been approved for the treatment of nausea and vomiting. This one has only been approved for the nausea and vomiting in AIDS wasting syndrome. Both of them have been approved for the treatment of nausea in cancer chemotherapy. Since 2006, a company in England has been able to market, or at least study, I should say, not market yet, but it's on the pipeline, an actual cannabis sativa extract, liquid carbon dioxide extraction of cannabis. Since '06, they're now conducting multi-center clinical trials in the United States on the treatment of pain and cancer conditions. And it's already been approved in Canada for the treatment of intractable pain, central pain syndromes in MS patients, multiple sclerosis patients. And interestingly enough, for over 30 years now, the federal government has had a supply of cannabis sativa cigarettes. So this is the only method of delivery that they are that's approved. For a few number of patients, receive an actual supply of cannabis sativa cigarettes from the federal government grown in Mississippi. The program was closed in 1991-92 due to some war on drugs politics, but currently there are 4 patients grandfathered into the program. This cannabis has been used in about 20 controlled clinical trials in the United States. And as I said, it has continued to be supplied to a number of chronic patients, but for the most part, it's completely off supply. I mean, nobody else can get access to it. There's no prescription access to it. There's no general medical access to it. It's in a very controlled, closed program. But so these all have different legal classifications, and this is not really an arcane legal issue because actually, the distinctions between these substances is a matter of kind of active cultural knowledge. So this is a cartoon here of education, drug prevention education on a Drug Enforcement Administration website that's targeted towards adolescents. So on the one hand, you have Dr. Pot, and on the other hand, you have Dr. Pat. So this is how one form of cannabinoids is validated and another form is invalidated. So this is an active site of not just pharmacological curiosity and arcane scheduling, but actual active cultural information. So because of this sort of hostility, or I would have to say misinformation, part of my research was to go and find out what exactly is this what the physicians in the system are like, and is this the medical advice that they proffer? How is it actually working? So 12 states in the United States have passed laws that sort of jumped past this sort of botanical versus chemical distinction and have allowed their physicians to practice cannabinoid botanical medicine. These states are in green here, as you can see. Only one state tried to pass it, but initially did not pass. And there's probably about 20% of the US population that lives in a state that recognizes cannabinoid botanical medicine as medical marijuana, and that's about 40% of the land mass, the total area of the United States. So I should also mention that a few states are considering this particular type of policy in this election year, most notably Michigan. In Washington State, our law is a matter of active public discourse. A lot of Well, very rarely do the Seattle Times and the Seattle PI actually have the same lead story. But one day I took some photographs of this story about his medical marijuana use, the reason to deny transplant, pot use suffering may have cost his life. There's active public debate about the medical marijuana laws, who's allowed, who's not allowed, who's punished, who's not punished. But there's not correspondingly an adequate amount of scientific research documenting what's going on in the system. The Department of Health had a medical marijuana rules workshop series across the state to discuss what's an adequate 60-day supply for patients. And they spent $94,000 on this project with the state legislature. So this is an active place of investment for our state. So in this law, we have, which voters passed here in 1998, by ballot initiative, we defined a new category called the medical use of marijuana, which means the administration, production, possession, or administration of marijuana for a qualifying patient in the treatment of his or her debilitating or terminal illness. As I mentioned, other states have the law, and also internationally, Canada, Netherlands, Spain, Israel, a few other countries also have developed at their federal level programs to allow medical use of cannabis. And just so we're clear, the university that we're at has also adopted a policy regarding medical marijuana, which allows physicians, UW physicians, who wish to provide such authorizations to their patients, certain guidelines to follow. So that's some of these validations allowed me to sort of move forward to conduct research. Again, these are, in our state, we have a specific list of qualifying conditions. You can look at them here. Everything from cancer to intractable pain to Crohn's disease, hepatitis C. And additional conditions can be added to this list through petitioning of the Medical Assurance Quality Commission. So in the first study that I did looked at the characteristics of patients who are accessing this treatment at one facility in Washington State. I chose to study a rural pain clinic. Just wanted to throw this up here to show you kind of some of the human side of things. This was a patient that was denied the liver transplant at the W Medical Center earlier this year. He's since passed away. This was the day that he'd been told not that he couldn't receive a transplant unless he went through drug treatment for 60 days. Ironically, he was authorized to use medical marijuana by a UW physician. So the study that was conducted here in Centralia, Washington, which is kind of traditionally a logging community, one of the committee members has a practice of pain medicine and physical rehabilitation medicine. So he offered his facility to conduct a medical records review. This is a picture of the medical charts that are sort of holding storage area in that clinic. And we did a study where only the patients who were authorized to use their records were pulled out, and with HIPAA authorization we were able to do chart reviews, revealing no identifying information. So doing that process revealed 139 patients. Just to give you some characteristics of those patients, 62% of them were male and 37% of them were female. Median age was 47 for male and 48 for female. The sample represented a total of 236 patient years of authorized medical cannabis use. That means number of patients times, or for each patient, how many years that they've been authorized to use medical cannabis by a physician, be it this physician at this clinic or other physicians they've seen in the past. And you add all those numbers up. So that's what it represents. And male-female was actually a disparity in that. Total, it was 145 male patient years and 91 for female patient years. So more patients have been accessing treatment at this facility who are male than females. Or I should say, treatment for medical cannabis. So if you're also interested, I was also interested in looking at where did these patients come from? What part of Washington State? So I was able to collect some limited background information, home zip code information. If you could hit the light, please, would you? You can see here, this is a dot density map showing what the three-digit zip code areas where the patients came from, and the vast majority of them were from the same area that the clinic was located in. One dot here represents 0.06 patients, so you got to sort of multiply it a little bit, but That's sort of the way it worked out, and it's randomly distributed, so these aren't real addresses or real locations. So randomly distributed within each 3-digit zip code area. But there's kind of a definite distance decay here, showing that patients aren't really all coming from one corner of the state or another corner, but actually from the very site that the clinic is located in. So let me just, I'm not going to go into too many details, but just wanted to let you know how the categorizations were then done. So I picked a couple of sample patients, and I just want to walk through real quickly what these patients looked like and how we then categorized them. So one patient was a female, 33 years of age, who was from zip code 985, who had been an authorized patient for 2.13 years.